guys, it's Dr. Courtney Burns, Doctor of Nursing Practice, and welcome back to the NP Consult. So on today's episode of the NP Consult, we're going to be talking a little bit about the menstrual cycle. So doing family practice, I do talk about the menstrual cycle from time to time, what is normal, what's abnormal, all the way from the beginning of the menstrual cycle to the end of the menstrual cycle. And I was recently asked to do a talk over the menstrual cycle at a local bar studio. So it got me kind of looking back into it and reviewing the menstrual cycle. It really is a pretty complicated system that has a lot of working parts to make it work perfectly. And I thought, there's probably other people out there that may benefit from a little review over the menstrual cycle. So today's episode is going to be over the menstrual cycle, and we'll also have a little bit of information about oral contraceptive pills. So I'll start briefly talking a little bit about the anatomy of the female anatomy of the reproductive system. So you do have the ovaries, which is what it's going to be releasing the hormones, and also going to be, have the follicles inside and also, release the egg. And then you have the fallopian tubes, which is really just the tube from the ovaries down into the uterus. And then the uterus is where the lining is going to build up and also then slough off. And then you have the cervix, which is the opening of the uterus. And after the cervix is the vagina, which is the opening out into the world. So that's just a brief, overview of the female anatomy. And then we'll talk about the physiology of the normal menstrual cycle, which is really just a very tightly coordinated, cycle of negative and positive feedback loops. It's going to involve lots of organ systems, including, the nervous system, your ovaries. It's also going to have some autocrine, factors in there, some of the stuff that they're really still just figuring out now. And it's going to, again, have the ovaries and also involve your pituitary and your hypothalamus. The menstrual cycle, day one of your menstrual cycle, is going to start on day one of your menses. And it is broken up into two cycles. So you're going to have two phases. You're going to have the follicular phase and then the luteal phase. And the follicular phase or the proliferative phase is going to start on day one of your menses and will go all the way until ovulation or the day before the luteinizing hormone surge. It really is going to average about 14 to 21 days. However, there can be a lot of variability when it comes to the follicular phase of your menstrual cycle. So there's going to be more variability in that phase than there is in the luteal phase. The luteal phase is going to start really at ovulation or with that luteinizing hormone surge, and will go until the day one of menses. And it is really going to last about 14 days and going to have less variability when it comes to, the luteal phase compared to the follicular phase. The menstrual cycle is going to start somewhere between 9 and 12 years old on average, and it can have a lot more variability at the beginning of, the first 5 to 7 years of menses. There's going to be a lot more variability, as there will be also more variability when it comes to the last 10 years of the menstrual cycle. It's going to really kind of peak its length really at age 25 to 30, and then we'll start to shorten after that. So women in their 40s might have shorter menstrual cycles, and really though between 20 and 40 there's going to be a lot less variation with the menstrual cycle at that time. So more variation at the beginning and end, but between age 20 and 40 there's really going to be less variation in the menstrual cycle. The follicular phase, again, is going to start day one of menses and then go all the way until ovulation, or really the day before the LH or luteinizing hormone surge. And the body temperature is also going to be a lot lower in the follicular phase. It'll start to raise when we get towards ovulation, but in the follicular phase it's going to be lower. Also, the characteristic thing of the follicular phase is going to be development and recruitment of follicles in the ovaries, where eventually, the follicle stimulating hormone is going to stimulate these follicles to, be selected, where eventually one is going to become the dominant follicle. And that one is going to obviously be destined for ovulation. The follicles actually can be seen on ultrasound. So if you've ever done like a pelvic ultrasound and seen follicles in the ovaries and you weren't really sure what that meant, depending on where they are in the follicular phase, that's really what the follicles are going to tell you on ultrasound. And then the estrogen levels, or the estradiol levels, are going to increase in the follicular phase. And basically they are going to peak the day before ovulation. And this is going to cause, some stringiness to the cervical mucus. Also, it's going to just continue to cause that endometrial lining to thicken. The pre-ovulatory basically the pre-ovulatory oocyte will release this estrogen, and the estrogen is what is going to eventually trigger ovulation. So that's all going on in the follicular phase. And then in then you have like the luteal surge and ovulation. Estrogen again is going to increase in, throughout the follicular phase, and then it will peak a day before ovulation, which is going to trigger some ovulation. Estrogen is then going to fall after that peak and will, raise a little bit throughout the luteal phase, but it will then decrease, right before menses. And what once was sort of a negative feedback loop between these hormones and the luteinizing hormone then becomes a positive feedback loop, and the luteinizing hormone surges and increases, which will cause the egg or the oocyte to be released, or will cause ovulation, which usually happens about 36 hours after that surge. So about 36 hours after you have that luteinizing hormone surge is when the egg's going to be released to go then down the fallopian tube. So in the luteal phase of the menstrual cycle, which is going to be that second phase of the menstrual cycle, and it's going to start with that, with ovulation, and it is going to last about 14 days long. And there's less variation again with this phase, so it really usually does last about 14 days. So if a woman's menstrual cycle is going to be any longer, that variation is coming from the follicular phase. And progesterone is going to rise throughout this phase, so it's just going to keep rising. And if that oocyte that was released is not fertilized, then it will, these hormones and progesterone will eventually start to fall, and that fall of that progesterone is going to trigger some other things, which we'll talk about in a minute. But if the oocyte is fertilized, then it's going to implant into the endometrium, and it will, it will have that progesterone continue to rise instead of fall. And that uterine lining is just going to continue to thicken throughout the luteal phase. And then if there is, no pregnancy, so in the absence of fertilization of the oocyte, the progesterone is going to withdraw. And when that progesterone withdraws, it's going to cause some constriction of the arterioles, which is going to cause some ischemia. So basically that lining of the uterus is going to constrict and cause some ischemia, which will then cause some decreased blood flow to the endometrial layers, and that decreased blood flow will cause some release of prostaglandins, and the release of that prostaglandins will then cause the uterus to contract and then start to expel the uterine lining, which is when the menses will start. And the menses usually last about 2 to 8 days, average being about 4 to 6 days. Normal amount of blood loss is about 30 mils during the menses. And if it's anything more than 80 mils, that is considered abnormal. So I will be putting this image in the description of the video, but I do think that this image is a good description of the menstrual cycle and all of the different things that are going on at the same time during the menstrual cycle. So it goes over the endometrial histology here and what's going to be happening during the menstrual cycles, day 1 through 28. and then also the hormones that are going to be happening during the menstrual cycle, what the body temperature is going to be doing, as well as our ovarian histology. So, what is the follicle going to be doing during the menstrual cycle? Kind of has a good view of all of these things that are going on at the same time. So day 1 through really 1 through 7 here, day 1 through 7 of the endometrial histology, so when menses starts, the follicle stimulating hormone is going to be released slightly here and is already going to be recruiting that cohort of follicles. And by day 8, the one dominant follicle is going to be chosen, and that follicle will continue to mature as the estrogen starts to increase here in the follicular phase, and then it will peak here the day before ovulation and also a day before the luteinizing hormone surge. And the body temperature is also going to increase here at ovulation. And the mature follicle has now, matured, and during ovulation, it will go ahead and release its egg. The follicle, or this, once the egg is released through ovulation, it becomes this corpus luteum. And if not fertilized, it will undergo atresia here and eventually die. The body temperature here will stay up throughout the rest of the luteal phase and then decrease at the end towards menses when the cycle starts over again. The estrogen will fall after that spike the day before ovulation, will go down in the luteal phase and stay up until it goes back down right before menses. Progesterone is going to be higher in the luteal phase than estrogen was. So in the follicular phase, estrogen is going to be higher than progesterone. In the luteal phase, progesterone is going to be higher. And then when we do not have a fertilized egg here, then the progesterone will withdraw, and both estrogen and progesterone will go down. And as that happens, then the lining here of the uterus will, the arteries will constrict, and that will cause ischemia. When that ischemia happens, it will cause release of prostaglandins, which will then cause the uterine lining to constrict and expel, which starts menses, and that will start the whole cycle all over again. So we'll talk a little bit about estrogen and progesterone, because those are the biggest hormones that play a part in our menstrual cycle. And I just really want to touch briefly on what we're going to feel from those hormones. Estrogen is going to be really the hormone that's going to cause us to have more breast tenderness or abdominal bloating. We could have some, peripheral edema, nausea, headaches, depression. So those are things that we're going to see from estrogen. And then from progesterone, really is going to be more androgenic things. So, maybe facial hair or increased, hair production, acne, anxiety, also weight gain. So briefly, we'll talk a little bit about oral contraceptive pills because I thought that it was kind of interesting to note that your body's really not going to do the exact same thing. Obviously, when it's has oral contraceptive pills going on, you're going to be getting those hormones, so it's not going to go through the same cycle. The combined contraceptive will suppress the menstrual cycle, obviously, but it's going to try to mimic it in different ways. And the uterine lining is not building up whenever we're on contraceptive pills, so it's really more of a withdrawal bleeding that you get from the inactive pills and not an actual menstrual bleeding. And then the withdrawal bleeding is really not necessary, so there are ways that we can delay that, or maybe skip, not have that withdrawal bleeding. And progesterone only birth control pills will suppress part of the menstrual cycle, but they're not going to suppress the entire menstrual cycle. So when you have combined contraceptive pills, one of those combination hormones is going to be estrogen. The most common estrogen that's going to be in the pills is ethinyl estradiol, and how it's dosed is, or how we're going to, pick a contraceptive is really based on its dose. So a low dose contraceptive with estrogen is going to be 10 micrograms to 25 micrograms. And then a medium dose is going to be 30 to 35 micrograms. And a high dose is going to be 50 micrograms. And for a new start or someone that's never been on birth control before, then it's recommended that maybe we just start with a medium dose estrogen. And then there are ways that we can decide, like, okay, if we need to go from medium to low, or maybe start with a low. And that would be if somebody has a lot of side effects that we think are estrogen related, then, and again, we talked about that's going to be things like depression, breast tenderness, nausea, peripheral edema, headache, those things that we might think be caused by estrogen, then you might want to lower that dose from a medium or high, I guess, to a lower estrogen. Also, if we think that the patient might be more at risk for blood clots, then we can go down to the lower dose estrogen. And then when to increase from a lower dose back up to a medium, or go from low to medium to high, is when if you're having significant breakthrough bleeding or irregular bleeding. So sometimes the low dose estrogens will cause more breakthrough bleeding or irregular bleeding. So if your patient is having irregular bleeding on the low dose estrogen, then you may want to consider going up to the medium or high dose estrogen. And even though the high dose estrogen is, considered 50 micrograms, and that is considered high dose, we really should be kind of rest assured that our own body is probably releasing more estrogen than that. So we don't really want to be overly concerned about it, but we do want to think about it with certain populations. And then the progestin part of the oral contraceptive combination pills, the way we're going to choose that is based on generation. So we have first generation through fourth generation, and I will put these generations in the description for you, and that way you can see them, because the first generation is going to be norethindrone, and the second generation is levonorgestrel, the third generation is norgestimate, and then fourth is drospirenone. And so again, because I probably butchered that, I will go ahead and put those in the description of the video, the generations of the progestin. And the earlier generations of the progestin, so the first and second generation, they are going to be more androgenic. So again, they're going to have more of those progesterone symptoms, which was going to be the anxiety or increase in hair growth or acne, weight gain. So they're going to be more androgenic, and they're going to be less thrombophilic. So they're going to have less risk of having a blood clot. So really the low dose estrogens and then the first and second generation progestins are going to have our lowest risk for blood clots. So the third generation is less androgenic, and it's also slightly more thrombophilic, and then the fourth generation is actually anti-androgenic. So sort of spironolactone effects when you get to the fourth generation of progestin. So if you were going to new start somebody on birth control when you're considering progestin, then the initial choice might be to start with the second or third generation. But if you're going to, when do you maybe move from an early to late generation, or maybe when to choose a late generation is when they're having more of those androgenic side effects. So if they're having more acne or more weight gain, more anxiety, then you might want to choose a later generation progestin and stay away from the first and second generations. But if you think they have a more risk for blood clots, then we will consider going with the more first and second generations. So really, those are just some things to consider when you are thinking about starting or changing patients when it comes to combined contraceptive pills. And then one other thing to think about is they have monophasic and triphasic. So monophasic is going to give the same dose of estrogen throughout, and progestin in each active pill. And they're really used to treat conditions such as endometriosis or menstrual migraines, because they can be used via extended cycling, or skipping those placebo pills and skipping the withdrawal bleeding. And so those can be treated, or that can be used to treat endometriosis and then the menstrual migraines. Triphasic doses are going to vary throughout the pill pack, and it's really meant to try to more mimic our endogenous hormones throughout our menstrual cycle. One is not really better than the other. And the triphasics can cause a little bit more breakthrough bleeding. So if your patient is having some breakthrough bleeding on the triphasics, then you may want to consider going over to a monophasic. And then there is progestin only. So progestin only, really, we're going to consider that for when estrogen is probably contraindicated in women. So if we are thinking they may really have a risk for blood clot, or they've had a blood clot in the past, or maybe they're older and they're a smoker, these would be reasons that maybe to consider using the progestin only. Also, if they have migraines with aura, or if they're breastfeeding, those would be reasons to consider the progesterone only. And they have to be taken at the same time each day. So that's something to remember about the progestin only. And just because of typical use of the medication, it does have a lower efficacy than the combined pills. But again, it can be very effective as long as it's taken at the same time each day. So I will definitely put the references, of course, at the end of the video for you guys. Also, don't forget to check out the consultation notes in the description of the video. And again, that's just a timeline of what we talk about in the video, so you can go straight back to that section if you needed to go back and wanted to hear about something, but you don't want to watch the whole video. And I just really hope that you guys enjoyed this video, or this episode over the menstrual cycle.